Hi, my name is Kysow and I'm studying to become a clinical psychologist. Within the field of psychology, there are many disorders to specialize in, whether that's as a psychologist or as a researcher. Globally, 1 in 10 people suffer from a mental health disorder. Some are extremely prevalent, such as anxiety and depression. Others are less prevalent, like anorexia nervosa or panic disorder. You likely know a loved one who has dealt with one of these disorders, or perhaps have dealt with one yourself. Research into each disorder is extremely important, as they all have unique symptoms and require varied intervention strategies. Unfortunately, the disorder I study is not commonly studied, and there are many unknowns about how to best intervene. I study hoarding disorder, which is characterized by difficulty discarding, intentional saving, and clutter that impairs the use of the living spaces, such as the bathroom, living room, or bedroom. Clients who hoard tend to have difficulty discarding because of their emotional attachment to their objects. Hoarding might seem like a problem that only affects a few people, but recent estimates suggest that 2.5% of the population, or 900,000 Canadians, are living with this disorder. Unfortunately, limited research exists and available community resources fall short relative to the need. There is a lack of understanding across the general population as to what hoarding is and how to help. Public stigma translates to people who hoard experiencing feelings of shame and self-criticism. They might avoid inviting friends or family into their home, and often they will go to some efforts to conceal their problem. Even if a client who hoards does put up their hand and says, "I need help," there aren't many mental health providers who treat hoarding. In fact, the more likely person to discover and intervene in a case of hoarding is a frontline professional in fire prevention, social work, nursing, or low-income housing. Most professionals work under the umbrella of harm reduction for hoarding, where the goal is not to decrease the hoarding behaviors necessarily, but to decrease the negative consequences of the behavior, similar to harm reduction efforts to improve or to promote safer sex and safer drug use. As clients who hoard may find it difficult to allow a provider to cross their threshold, relationship building is often the first step. In an ideal situation, there are a number of client-centered strategies available, such as case management, decluttering coaching, and peer support services. However, if there are significant health and safety hazards that affect neighboring tenants, such as pest infestations or clutter blocking the exits and entrances into a home, a cleanout may be used. One day, a team shows up, they clear the clutter out and drive away. This strategy will likely improve the health and safety of the overall community. For instance, by removing the clutter, the risk of fire decreases in a hoarded home. A cleanout might also help prevent a client's eviction, which might protect a low-income tenant from homelessness. However, the client might be left with an empty home and likely no strategies to help manage their distress or to prevent a reoccurrence of the problem. Anyone would find it difficult to watch their possessions being taken away with a little say in their matter. Community agencies are left in a challenging position. They need to balance the rights of the client to live the way they want with the health and safety of the community. In addition, no descriptive data exists to help guide decisions about whether or not to undertake a cleanout intervention and how to do so. For my public scholar work at the Center for Collaborative Research on Hoarding, I'm surveying frontline professionals from Fraser Health and the Toronto Hoarding Support Services Network about their experience conducting a cleanout. I want to understand what necessitates cleanouts, what happens during an intervention, and what happens after. I also want to hear from clients themselves. What is their experience having a cleanout intervention? What made it more difficult and easier? Did they choose which items remained in the home and were removed? How much input did they have into the experience as a whole? Training and resources for hoarding are often limited. but my hypothesis is that strategies used for other social problems like relationship building, increasing client autonomy, and providing clear rationale and opportunity for discussion and choice may be effective in cleanout interventions too. I'm curious to find out when these strategies are used and how clients can be better supported. If a cleanout has to be implemented, how can it be done in a way that is non-stigmatizing, that puts the client at the center of the intervention, and as a harm reduction strategy? There is a lot to learn about community interventions from the community itself. My research is centered on describing what they are doing, what's working, and how can we develop best practices that support frontline professionals in providing better care. I'm interested in this work because I've seen firsthand how challenging the work community providers are doing with clients who hoard. And I also understand how upsetting it can be for a client to experience the cleanup process. I want to understand their experience and to help make it easier. I'm just starting out on this research journey. Although I have some research partners, I'm looking for others. If you are a client who hoards who has experienced a cleanout, or a service provider who has conducted a cleanout, please join this research. The more partners, the better able we will be to develop our interventions and to better support clients who hoard. Thank you.